My name's Paul Marik. I'm from Eastern Virginia Medical School. I'll be giving the first lecture on assessing fluid responsiveness. Following me, Dr. T.J. Gann from Duke will be giving a lecture on perioperative fluid therapy. And then Dr. Heerdt will be talking about bioreactance and hemodynamic optimization in the perioperative patient. So if you could all take your seats, and we'll begin in a few seconds. Okay. So just give you an outline of my talk. We're going to talk about what is fluid responsiveness, why is it important, how to assess fluid responsiveness, and we'll go through a case study. So the question is, what is the question, or what is the right question you should be asking? So these are the wrong questions. What's the patient's preload? What's the CVP? I think we've all gone beyond that now. We don't even need to talk about it. Is the tank full? As we know, patients don't have fuel tanks. What's the cardiac output? And what's the stroke volume variation? So in terms of assessing volume responsiveness, these are the wrong questions. So really there's only one question which you need to ask when you're confronted with a hemodynamically unstable patient. And that question is my patient fluid responsive? And in other words, what we mean is that, will the patient's stroke volume increase by giving a fluid bolus? And that's really what you want to know. If the patient's stroke volume does not increase, it serves the patient no useful benefit in giving the patient fluid. So really, as I said, the only reason to give fluid is to increase stroke volume. And what we know now pretty well, that only about 50% of hemodynamically unstable patients in the operating room, in the ICU, in the emergency room are fluid responsive. So that means 50% of patients are non-fluid responsive. And what we also know that a positive fluid balance, as I'll show you, is associated with increased mortality. So clearly what you need to know is, where's the patient on his or her Frank-Starling curve? Really, that's what you need to know. Is the patient down here and is preload responsive, or is the patient up here? It's not going to respond to fluid. So when we talk about fluid responsiveness, it's generally defined as the increase in stroke volume or cardiac output of greater than 10% in response to a fluid challenge. And really what it means is the patient has biventricular preload responsiveness. So both ventricles need to be preload responsive. So I'm sure many of you are aware of this algorithm. So this algorithm was from the early 1820s and currently is outdated and should really not be used in fluid management. Unfortunately, many people still use this flow diagram. And it's actually pretty pervasive. We were in China recently, and on their flow sheet you can see the CVP. So what when we misguided in the US, we sometimes don't realize what an influence we have in the rest of the world. So not to make a long story short or a short story long, this was a systematic review we did on the CVP. And basically the conclusion was this systematic review demonstrated a poor relationship between the CVP and blood volume, as well as the ability of the CVP to predict hemodynamic responsiveness to a fluid challenge. And the CVP should not be used to make clinical decisions regarding fluid management. And I think that was 2008, and I think the data now is even stronger. And, I think that there is absolutely no place for CVP monitoring in critically ill patients. The only exception may be patients with acute right ventricular function, right ventricular failure. So in terms of fluid management, there is no place for CVP monitoring. And although some people still like to use the swan, I'm sorry to say the swan is dead. He died a really tragic death. And I think we know the SWAN does not improve patient outcome, and unfortunately it provides misleading information which results in inappropriate clinical decisions. So really there's very little role for the pulmonary artery catheter in this era. This is a slide from the F.R.C.A study, just to make the point. So they looked at the CVP at 12 hours as a function of survival. And you can see that those patients who met the Surviving Sepsis Campaign guidelines of a CVP above 12 had the lowest survival. Okay, so these are the targets you need to achieve, and those are the patients who had the highest mortality. I don't think we need to say anything more. So why is this important? So the cornerstone of treating patients with shock remains as it has been for decades, intravenous fluids. Surprisingly, dosing intravenous fluids during resuscitation of shock has been largely empirical. Too little fluid may result in tissue hypoperfusion and worsen organ dysfunction. However, overprescription of fluid carries its own risks. This is a famous quotation. So I think this is really nicely illustrated in this slide. So this is data from the ARDSNet group. They did a cumulative analysis of all their studies. They looked at cumulative fluid balance over time. They divided the patients into survivors and non-survivors, which is two pretty easy to define groups. And you can see that from the first day on, there was a clear separation in terms of positive fluid balance. So those patients who died had a significantly positive cumulative balance. And there are now numerous studies which show this fact, so that increasingly positive fluid balance is associated with a bad outcome. So again, going back to the F.R.C.A study, they looked at, this is fluid balance in the first 12 hours. So this is important because it kind of runs parallel to the early goal-directed therapy of the 6-hour goal. So you can see the patients that had the highest cumulative balance at 12 hours had the lowest survival. Again, clearly demonstrating that excess fluid loading results in increased mortality. So really the bottom line is you need to give them as much as they need and not a drop more. The problem is, when do you know when you've reached that sweet spot? This is a nice cartoon from an Anesthesia journal, which really shows this very nicely, that you really want to be here, right in the middle, that both under and over resuscitation is associated with significant risks. So really, when you resuscitate patients, you want to make sure that they're really in the sweet spot here. Fortunately, we now have new technology which can help us in resuscitating patients. So I think the days of the CVP and the SWAN are really dead. So I think the first thing is bedside echo. And I think this is, every intensivist should have the basic skills of doing bedside echo. It is so valuable in the immediate management of patients. So just as an example, Just as an example, if you have a patient whose LV looks like this, while you're busy resuscitating the patient, it tells you something, as opposed to a patient, oh my goodness, who's got an LV that looks like this. So really dynamically at the bedside, you can assess LV function. And what's important is this changes with time. Studies have really shown that patients who come in with normal LV function will develop LV dysfunction with time. So one can dynamically, in real time, assess LV function. So what about non-invasive assessment of cardiac output? And the real value of this number is not its absolute number. So if the cardiac output is 2 or 2.4, really doesn't help you much. What you really want to know is how the cardiac output changes with a therapeutic intervention. So there are a number of minimally invasive or non-invasive technologies, including transpulmonary thermodilution, pulse contour, which has become quite popular, and there are basically 3 commercial devices, Vigilea, FlowTrack, Pico, and Lidco, and Bioreactance, Nikon, which we're going to talk a little bit about. So there are 3 basic systems for pulse contour analysis. They use different algorithms to measure cardiac output, kind of illustrated on the slide. So they use the area under the curve together with changes in aortic compliance. The flow track system is an uncalibrated system. Both PICO and LIDCO are calibrated. PICO is calibrated to transpulmonary thermodilution, LIDCO to lithium dilution. So really, when one looks at pulse contour analysis, there are two questions you have to ask yourself. Is it accurate? That means, is the cardiac output you get reasonably accurate? And a number of authors have used the cutoff of less than 30% percentage error. So if the error is greater than 30%, the device is not inaccurate. But more importantly, does it accurately track changes following a therapeutic intervention? So I was kind of interested in FlowTrack because it's gained quite a lot of market penetration. It's the device which is often used in the operating room because it's easy to use. You just stick it on the A-line. And surprisingly, there have been a whole host of studies that have actually looked at the accuracy. So this is data which is published. I haven't invented this data. So there are 42 studies published, and as you'll see, what's happened is the first iteration of the device the performance was less than stellar, so the company came out with a newer software version, which again wasn't too stellar. They then came out with a newer version to correct the problems of the previous two versions. So as you can see, the threshold of accuracy is 30%. You can see, on average, all of these iterations were above that threshold being unacceptable. And as you can see, 16%, 0%, 13% actually of devices met the accuracy level. There was then a fourth and most recently a fifth iteration of this device. And you can see, unfortunately, the precision and accuracy of this device hasn't increased, which is kind of quite remarkable. People use this. What's more disturbing is the ability of this device to track changes in volume, changes in cardiac output in response to both volume and vasopressor agents. So this was a recent study which looked at that. So they're using area under the curve analysis. This is FlowTrack here. This is PICO transpulmonary thermodilution. So probably the most important question you want to know is, if I give fluid, is cardiac output going to increase? This device is unable to give you the answer. It's in 50% of the time it's going to be wrong, whereas the PICO is much more accurate. And then when they looked at changes when you changed afterload, was this device adequately able to track cardiac output? And you can see what happens. So this is the FlowTrack device. This is transpulmonary thermodilution. So as you change afterload with phenylephrine or norepinephrine, the pulse contour formula cannot correct for this change in aortic compliance and for falsely give you increases in cardiac output. So this device is inaccurate at baseline and unfortunately doesn't track changes in cardiac output to volume or vasopressors. So it's, I'm not sure what its value is. It's kind of remarkable people use this device. This is the third generation device. So this is a publication, British Journal of Anesthesia, 2012. It's still in a EPUB before publication, which again, this is the third generation device. Again, looking at volume responsiveness, shows exactly the same thing. So it really begets the question, who would ever want to use this device and why they would want to do so? And I think maybe it's supported by this study, which is kind of interesting. So this was a randomized multi-center study in 3 ICUs. They looked at emergency ICU missions who were hemodynamically unstable. They randomized them within 6 hours to FlowTrack or standard of care. And the primary outcome was the percentage of patients achieving hemodynamic stability in 6 hours. That was the primary outcome. They weren't really looking at clinical outcomes. And remarkably, that patients with the standard algorithm or standard approach, more patients reached stabilization than those who are using this so-called cardiac output device, which really doesn't speak well for them. And indeed, if one looked at secondary outcomes of ICU mortality, length of stay in the ICU, they were worse with this non-invasive device. So I think the lessons from the study is, one, if you use a device, it needs to be accurate. You need to be able to use it in both intubated and non-intubated patients alike, which is a big drawback with some of these devices that use stroke volume variation. It needs to be cost effective. And then most importantly, you need to have a plan. You can't just give your clinicians a device without giving them some kind of instruction or plan on how to use the device. So really, just to remember that a fool with a tool is still a fool, that if you give them a device, it's not going to make them understand hemodynamics any better. So many people use stroke volume variation to help them assess fluid responsiveness based on their heart-lung interactions during mechanical ventilation. And this kind of became or has been quite popular. However, what we've come to realize is that this technique has an enormous number of limitations. Firstly, patients have to be in sinus rhythm. Secondly, they have to be deeply sedated or paralyzed. They need to have volume cycle ventilation with a tidal volume of at least 8 mils per kilo. If you use less than that, it becomes inaccurate. There must be no patient-ventilated desynchrony. It's markedly affected by changes in both chest wall compliance and pulmonary compliance. It becomes inaccurate in patients who have cor pulmonale or pulmonary hypertension, and it becomes inaccurate in patients who have increased intra-abdominal pressure. So clearly you can see that there are a whole host of factors which limit the value of this technique. And unfortunately, all of the studies that have been published were done in the controlled setting of an operating room under very controlled circumstances, which really don't reflect what happens in the real world. And even in the optimized setting, this is a recent paper by Dr. Cannison, who showed that in patients who have a pulse pressure variation between 9 and 13%, it's impossible to be able to predict volume responsiveness. So there is this gray zone, which is often where patients land up, in that it becomes the predictive ability to predict volume responsiveness disappears. And again, this is a paper in British Journal of Anesthesia about to be published, and they looked at dynamic indices in the real world, both in the operating room and the ICU, and found them to be unable to predict volume responsiveness. They were poor predictors. So the problem with using stroke volume variation and pulse pressure variation, it seems to work in highly sedated patients who are synchronous with a ventilator in a very controlled environment. But in the real world, it seems to have limited applicability. So what about bioreactance? So we're going to talk a little bit about bioreactance. So this differs from bioimpedance. So with bioreactance, you have electrodes which emit an electrical signal. You then have electrodes which receive the signal. With bioimpedance, one looks at the change in amplitude. With bioreactance, one looks at the phase shift. So that's the way the direction of the electrical signal changes. So pulsatile changes in thoracic volume, which is stroke volume, induce a phase shift, which are continuously being detected by NICOM's phase detector mechanism and captured in the form of a NICOM signal. So instead of looking at the change in amplitude of the signal, it looks at the change of phase, which is the angle. And that's related to the dynamically the stroke volume in the thoracic aorta. So this is schematically what it looks like. You have 2 electrodes on each side, an emitting and a receiving electrode. And the formula, this is the formula for stroke volume, which is a constant times the ventricular ejection time, which it gets from the EKG signal, and that is the phase change. So it's the phase change over time. So it's important to note that, look at this formula, which differs significantly from the formula which is used to calculate bioimpedance. In bioimpedance, you need the distance between the electrodes, and that becomes an enormous limiting factor in bioimpedance. With bioreactance, it's independent of the distance between the electrodes. So therefore, the nurse can just slap them on the chest, doesn't have to accurately measure the distance between the electrodes, and really it's not affected by the baseline thoracic impedance. So this is one of the first validation studies in which they put a flow probe around the aorta and pulmonary artery. So this is the aortic flow. These are EEG signals. This is the phase shift, and this is the phase shift per time. And you can see how closely it mimics the aortic flow pattern. And then what they were able to do is change cardiac output using cardiac output on patients with cardiopulmonary bypass. So you can see this is thermodilution, this is NICOM. You can see how precisely they follow each other. They track each other very closely with a very good correlation between the two. This was a more recent validation study comparing NICOM to thermodilution. And as you can see, the error was 9%. So before we said the threshold is 30%, the average for the Vigileo system is about 45%. So this is, in terms of accuracy, much more accurate than the Vigileo system. This was a study reported in abstract form at ATS in patients with pulmonary hypertension. What was interesting is they compared bioreactance to thermodilution as well as the F.R.C.A. And in fact, using F.R.C.A as the kind of gold standard, very close approximation between NICOM as opposed to the precision of pulmonary artery catheter thermodilution was a little bit wider. And what they did is they gave adenosine as a pulmonary vasodilator, and they looked at change in cardiac output, and there was a very close correlation between the pulmonary artery catheter, thermodilution, and NICOM. Closely tracked the change in cardiac output. What we use is standard of care actually now in our ICU is passive leg raising. It may seem socially inappropriate to lift a patient's legs high in the sky, but it actually is a very valuable therapeutic maneuver. So what we do is patients start off sitting up, we put their head down and their legs up. That is equivalent to giving them an instantaneous fluid challenge of about 350 to 500 cc's. With that, what happens is you shift the preload to the right, and then depending where the patient is on his or her Frank-Starling curve, it tells you if the patient's over here, preload unresponsive, or the patient's here, preload responsive. So just by measuring change in cardiac output with lifting of the legs, you can tell where the patient is on his or her Frank-Starling curve. So it mimics a fluid challenge, but you're not giving fluid, and is quickly reversible. This is a study, meta-analysis looking at the diagnostic accuracy of passive leg raising in critically ill patients, and as you can see, the ROC curve was about 0.95. So a very highly predictive method of determining fluid responsiveness. So we currently do this in the emergency room. We do this in the ICU. Our nurses do it, becomes part of the standard of care. So when I'm on call, they call me and say, oh, patient's fluid responsive, patient's not fluid responsive. It's really easy to do. You just have to lift up the legs. You put the little stickies on the patient's chest. I don't know how more non-invasive you can be. It takes about 5 minutes to set up, and it's been remarkably really well accepted by our nursing staff and our residents. They do it themselves. This is a study which looked at the predictability of passive leg raising to predict volume responsiveness. So this is an example of a patient. Lift up the legs, cardiac output increases. Patient gets fluid, cardiac output increases. And the correlation between the increase in cardiac output with passive leg raising as well as fluid, which was very closely allied. So the question is, why don't you just give patients a 500 cc bolus and see what happens to the stroke volume? Rather than messing around trying to predict who's going to increase or decrease, give them 500 cc's of fluid and see what happens. I'm unaware of any case reports. Diet Coke's about 350 cc's of anyone who's died of volume overload from Diet Coke. So you may kind of recognize this little algorithm. This is kind of a mock-up of our version. So basically what we do is we put on the little stickies, we give the patient 500 cc's, and then we see their stroke volume increases or decreases. If it increases, we keep on doing this cyclically until the patient is no longer volume responsive. We then see their map, and then depending on where the map is, we will give them presses based on that. So we think this is a much more physiological method of volume resuscitating patients. You give them fluid, you see the response, and you keep on doing this until they're no longer volume responsive. So we've been actually collecting data with a number of devices, and I'm going to quickly go through them. So we do this simultaneously in all of our patients. We have the PICO here, we have an echo machine here. We look at both the heart as well as carotid blood flow and blood flow in the branchial artery. We measure end-tidal CO2, and when we do PICO at the same time. This was one of our nurses, because we were interested in are healthy humans volume responsive. So our nurses are already quite into this technology, so they were quite happy to volunteer for this little experiment. One of the other things we were interested in is what happens to humans standing on the head, because giraffes actually, when they drink water, their head is about 2 meters below their heart. So they have to develop some mechanism to prevent them getting cerebral edema, and we wondered if the same mechanisms apply in humans standing on the head, and the good answer is that they do. So humans act like giraffes. So basically, just to summarize the data we have, we've got data on about 100 patients and 50 volunteers, including about 12 Navy SEALs who respond quite differently. So what we found is that, as the literature suggests, 50% of patients were fluid responsive. In our healthy people, not super athletes, so we found that 100% of adults who are not super athletes are volume responsive. And what's really interesting is their stroke volume increases by about 33%. We simultaneously measure their carotid and branchial flow, and as you can see, it only goes up by about 19%. We found that pulse pressure variation was totally unable to predict volume responsiveness. We found that the concordance between passive leg raising and using carotid blood flow as an indicator was almost 100%. What was really fascinating is then we looked at hemodynamically unstable patients, and what these people do is preferentially shunt blood to the brain. So on average in the volume responders, the stroke volume only went up 24% compared to about 33% in healthy controls. But what was fascinating is their carotid blood flow, so this is absolute blood flow, not velocity, went up 78%, whereas the branchial flow only went up 14%. So this has a number of really interesting implications. Firstly, clearly the brain is a preferred organ, and that when one's in shock, as part of evolutionary response, we shunt to our brain, our heart, and our kidneys, so that when you resuscitate patients, they're going to preferentially shunt to the brain, and they're going to divert blood away from the branchial flow, so that the worst place to monitor for volume responsiveness in hemodynamic unstable patients is the radial artery. So I'll quickly show you a typical case. And then what we can do is our next speakers can come up and we'll have a question and answer afterwards. So this was a 65-year-old male with ischemic cardiomyopathy of EF of 10%, had severe emphysema. Like many of these patients, he was a full code. He was being treated for end-stage cardiomyopathy and pulmonary infiltrates. He was getting escalating dose of loop diuretics, because we all taught that you treat heart failure with diuretics. And for whatever reason, he was given milnirone. So he was admitted to the ICU for respiratory failure and cardiorenal syndrome. So what we did is we checked him for volume responsiveness. Isn't this such a bizarre thing? So our nurses and cardiologists don't get this. This is a patient who has an EF of 10, and yet we wanted to see, was he volume responsive? So what did we do? Just to prove the fact that actually he was a little bit sick. You can see this was real time. So real time we did an echo, and I think you can see his massive LV there. So what do? We lift up his legs, and he increased his stroke volume by 20%. Can you imagine such a thing? Giving a patient with heart failure fluid and increasing his stroke volume. Not only did we do it once, not only did we do it twice, we did it 3 times. So this is a patient with end-stage heart failure who we gave 1,500 cc's of fluid. What happened? His cardiac output went up, his cardiac index went up, and this is his carotid blood flow. So you can see this is his baseline, 411, went up to 524. So preferentially, again, shunting blood to his brain. So this is how we do it. We measure the flow, we know we can accurately measure the diameter, and we can measure cerebral blood flow. So in this patient who was in heart failure, we fluid loaded him, we increased his cardiac output, we increased perfusion to his brain, and presumably to his kidney, because his BON came down, and surprisingly, although we fluid loaded him, we increased his cardiac performance, and his X-ray got better, and he was extubated and discharged from the unit. So just to finish, these were 2 patients who were in the ICU this week. This on the left is a patient with myxedema coma, had a TSH of 210. And what was fascinating, we did Doppler studies, and you can see that minuscule blood flow with a complete absence of diastolic flow. So this patient obviously was hypermetabolic. The patient's temperature was 32 degrees. The patient's brain obviously didn't require oxygen, so the brain was able to regulate its blood flow. Contrasted with this patient who's in cardiogenic shock, who had a stroke volume of 12, who obviously didn't have adequate cardiac output. So you can see what happened in this patient. He was shunting the blood to his brain, and you can see the marked increase in diastolic flow. So this really is a fascinating area that we're looking at. So, when one looks at stroke volume, the question is, where's the blood going and how's this being redistributed? Anyway, I need to thank our nurses. They really like this technology. It's at the bedside. It's physiologically based. They can participate in the care. And I think if your nurses like it, then I think you've won half the battle. And this is my colleague, Dr. Levitov, who will put an ultrasound probe wherever he can find a patient. Thank you. And this is a little interesting cartoon. Beware of crocodiles. This is a real warning sign. So thanks. And with that, I'd like to introduce our next speaker. I took a few minutes extra, Dr. Gann from Duke. Thank you.
Thank you very much, Paul, for that introduction. Good evening, ladies and gentlemen. First of all, I'd like to thank Cheetah Medical for putting this symposium together. Having heard Dr. Marik tell you about fluid responsiveness, as well as some of the technology measuring fluid responsiveness, what I'd like to do is how does one apply this technology in our day-to-day care of our patients? And one of the strategies that have been extensively investigated is goal-directed therapy, and commonly known as hemodynamic optimization. So how does one use this technology to help us to apply to our patients to try to improve patient care? Goal-directed therapy, good idea, but does it actually really make a difference? So let's take a look at what we're going to discuss. So what I'm going to do is, first of all, talk a little bit about consequences of hypovolemia as well as hypervolemia. And then we will introduce a concept of goal-directed therapy. I'm going to show you some data that looked at the effect of goal-directed therapy on post-operative outcomes. And then we're going to talk a little bit about a protocol, an algorithm that we instituted in our hospital about 18 months ago, and incorporate some of the evidence-based improvement in outcome, both pre, intra, and post-operative strategy to enhance this recovery from surgery. And lastly, show you a little bit of a study that we recently completed comparing NICOM, which is the Cheetah device, and esophageal Doppler for goal-directed therapy. A few years ago, we did this, wrote a review, really trying to look at what is the practice of fluid management. And in fact, if you go around the country and in fact go around the world, most of our practices on fluid management has been historical. And in fact, there's very little change over the last several decades in terms of fluid management. Now, we know that hypovolemia is bad, and hypervolemia is bad, as Dr. Marik showed you earlier. So if you have a patient that is hypovolemic, resulting in inadequate tissue, resulting in cell hypoxia, and your cell is not working very well, lactic acid accumulation, resulting in metabolic acidosis, your failure of your sodium-potassium pump, and if you don't really take steps to reverse that, the patient go down that track, resulting in multiple organ dysfunction syndrome. And as you know, when you get down here, the patient's morbidity and mortality is very high. Now, on the other hand, I showed previously that if you have patients that have fluid overload, positive fluid balance is also bad. And this study, again, very similar to what Dr. Marik shows you, that if you have a higher fluid positive or fluid balance, you have an increase in mortality in ICU populations. So where we really want to be is to avoid hypovolemia as well as hypervolemia and trying to be in this optimal range of optimal fluid balance. And we also know that both hypovolemia, in particular resulting in bowel ischemia, and hypervolemia can result in edema, which again can interfere with organ functions. So the question is that goal-directed therapy or hemodynamic optimization, does it really make a difference? And what are the target goals? Which patient populations should we apply to? What are the monitors? Which monitors should we use? And how does one achieve the goals? And these are certainly pertinent questions. And I'm going to try to look at some of each of these questions in the next few slides. Now, when you examine the literature, as far as goal-directed therapy, you can break down into three different populations. Those studies, they were done in the intensive care, critically ill patient populations. Those studies that were done in the perioperative, in particular intraoperative optimization of fluid and hemodynamics. And another category is those patients who, after their surgery, and you optimize them in a post-operative environment. So let's just take a look at some of these studies that in these three different areas. Now, this is probably very familiar to you, this study by Manny Rivers, who is both ED physician as well as intensivist. And essentially what he did was to randomize patients who had a diagnosis of sepsis who came to their emergency room, and instead of waiting for hours before they get to the ICU and started resuscitation, he said, why don't we start resuscitation in the emergency room and therefore improve patient outcome? So what he did is, again, following this algorithm that was previously shown, initially using volume to optimize volume status, although, again, using the central venous pressure, which, again, has been shown to be not very responsive and effective. Once the volume is optimized, then he optimized blood pressure using pressors as necessary, and then following that, optimizing delivery, and he monitored that using the central venous saturation, either using inotropes. So using that algorithm, he was able to show that in those patients whom were fluid optimized as well as using inotropes and pressors, that they resulted in improvement in outcome, and particularly in the mortality of these patients. As you've shown here, at 28 mortality as well as 60 days mortality, there was an impressive about 15% lowering of mortality in the group that received this early goal-directed therapy. Now, subsequent to that study, there have been a lot of other studies that has also been performed, and in fact, there is currently 2 or 3 large ongoing trials trying to replicate these data, and one of which is being directed from Pittsburgh and which is still recruiting patients, trying to recruit just under 2,000 patients randomized into either early goal-directed therapy, protocolized standard of care, or the usual care. And I understand that these studies are on the final phase of recruitment, so hopefully we'll have more data. What about in the perioperative period where we take care of these patients on a routine basis undergoing elective surgery? A number of years ago, we did this study looking at goal-directed therapy, trying to improve perioperative outcome in routine elective surgical patients. Using an algorithm which is, again, very similar to the previous one, and essentially what this study did was to look at, first of all, volume optimization. And again, to go back to basics, first of all, you've got to make sure that the volume is optimized. So using the esophageal Doppler monitors, we use volume to try to, again, optimize cardiac output and stroke volume, getting up the top of the Starling's curve. And just optimizing volume alone, and in fact, very few patients we actually needed to use pressors and inotropes, just mainly volume, we were able to show a difference in terms of both hospital length of stay. On average, they were staying a couple of days less in the protocol group compared to the control group, primarily because these patients were able to eat and drink a couple of days earlier. And as you know, most of you who work in a U.S. hospital, once your gut is working, you get out of hospital typically the following day. You don't stay any longer. And usually what we found is that the reason patients stay in the hospital is because their gut is not working. And once the gut is working, you get out of hospital. And we also found that some of the gut-related adverse events, such as nausea and vomiting, as well as the bowel function, also significantly improve with the goal-directed group. Other studies, again, have shown that with the goal-directed therapy, improving patient outcome, and this study, in fact, also looked at some of the inflammatory mediators and found that in the goal-directed therapy group, some of the inflammatory mediators, such as interleukin-6, was significantly reduced in terms of the rise. The raise of the IL-6 is far lower compared to the standard of care group. So clearly, there is some mechanical basis that goal-directed therapy improving perfusion and therefore reducing inflammation in the post-operative care. What about high-risk patients who had surgery in a routine fashion and then post-operatively, they have optimization? So these are some of the studies that came out from the St. George's group looking at early goal-directed therapy after major surgery. And again, using a oxygen delivery model and the relatively non-invasive cardiac output monitors, first of all, using volume, which is then followed by, once volume is optimized, using pressors as well as inotropes, again, to optimize both pressure as well as flow. And again, using this fashion of improving both the optimization as well as fluid, they were, again, able to show a reduction in both complication rates, so the stay in the hospital is significantly shortened, as well as complications in these patient populations. So there have been really quite a lot of studies done in the intensive care unit, in the perioperative period, suggesting that goal-directed therapy seems to improve outcome. Last year, there was a systematic review that was published in Anesthesia and Analgesia. Colin Hamilton and his group, essentially looking at all the studies that have been done over the last 20 years or so on perioperative fluid optimization. And this was a collection of about 30 studies. And essentially what the conclusion was that goal-directed therapy not only improved mortality, as has been shown here, but also lower complication rate in these studies altogether. So if you look at the collective studies, the result from all these studies, the complications incidence was significantly less in the goal-directed therapy group. Now the question I'm commonly asked is that, what should be the goals? What monitors should we use? Is it important if I use fluid only, or should I use inotropes? What about supranormal goals, as espoused by Shoemaker and colleagues many years ago? Should I achieve a supranormal goals or just a normal goals? Interestingly, these meta-analysis, they looked at some of the subgroup analysis, and what they found is that whether you use one versus the other monitors, or you use fluid or inotropes, or it depends on the goals you use, whether it's cardiac index or oxygen delivery or stroke volume, it really doesn't matter. The important is that you use a goal and stick with the goals, and it seems to improve outcome. If you look at the odds ratio of all these subgroup analyses, they all seem to confer advantages, whether you use the different monitors, different resuscitation, or whether you have supernormal or normal goals. So that suggests that it's not just specific to either a particular device or a particular strategy, but having a goal-directed therapy seems to improve post-operative outcome. More recently, there was also this meta-analysis has been published suggesting that goal-directed therapy may also reduce acute kidney injury. And again, this is a collection of studies looking at meta-analysis, and the authors concluded that at least surgical patients receiving perioperative hemodynamic optimization are at a decreased risk of acute renal kidney injury. Now, what about the type of fluid used? And also recently there's been a lot of literature, especially in the surgical literature, about this wet versus dry, liberal versus restrictive fluid administration. So how does one make out these different strategies? So this is an animal study in the pig model where the investigator were interested in looking at the difference between this liberal versus restricted fluid regimen as well as a different type of fluid that was used. So they randomized this group of pigs into three different strategies. First group received goal-directed therapy with colloid, initially with a bolus, 250 mils of header starch. The second group received goal-directed therapy but with crystalloid, and they both groups trying to achieve a target of mixed venous saturation of above 60%. And the third group had a restricted crystalloid therapy. So if you imagine that these two groups is a sort of goal-directed therapy group, the last group is this restricted or the dry approach of fluid administration. So they treated these pigs for 4 hours, and then they measured tissue oxygenation in the bowel mucosa. So this is almost simulating the colorectal surgery where you anastomosis the bowels. So what did they find? What they found was that those pigs who had goal-directed therapy targeting a mixed venous saturation of above 60% using colloid had the most increase in tissue oxygen tension as well as microcirculatory blood flow in the colonic mucosa, suggesting that these pigs was much more effective in terms of delivering oxygens, therefore have an increase in the oxygen delivery, therefore the tissue may heal much quicker. Compared to those pigs that receive crystalloid, and again a goal-directed approach using crystalloid is less increase in the oxygen tension, but those that has least increase, and in fact almost no change, was the group that received restricted crystalloid therapy. So again, suggesting that if you want to be most effective in your goal-directed strategies, you've got to use, again, the right sort of fluid, and again, having the right target to try to improve oxygenation. Now, while you may think that there's so much data, as I showed you earlier, there's about, in fact, more than 30 studies that have been done in goal-directed therapy, but it's not commonly done. And we wrote an editorial last year, and again, saying that despite all these promising results that I showed you earlier, the technique is still not widely adopted. Why is that? Well, I think partly it's because, first of all, there are a number of multiple devices, and people get hanging out like, what sort of device should I use? And also, I think we haven't been really educated on the improvement in the outcomes of these patients that we apply this strategy to. But I think we are at a sort of almost like a turning point, and I think that the future, I think, is going to be much more sensitive to outcome of the patient because the change of healthcare is coming. So I would say that, minimally invasive cardiac output monitor, in fact, in the coming years, I think will be much more widely used. And in fact, in order to do individual goal-directed therapy, to monitor these patients. Gone were the days where you can apply for a standard formula saying that you give this patient 4-5 mils per kilo per hour, and then you just sort of calculate a formula regardless of the type of procedure, regardless of the type of patients, and some patient may be, certainly come to us with a different fluid status, even from the beginning. And in fact, Hendrik Heerdt, again, echoed the same message. In a number of studies that has been done, one of the conclusions of the study suggests that we should focus an individualized goal-directed fluid administration rather than just using a formula that applies to everyone. Now, as I mentioned earlier, U.S. healthcare is changing. And with the accountable healthcare, this is what we are going to be facing with. So the payer will pay you a fixed sum of reimbursement, and you got to figure out how can you minimize the cost and improve patient outcome. And one of the most effective way to reduce cost is trying to reduce patient length of stay. So about 18 months ago, we started this fast-track recovery, or what we call enhanced recovery after surgery protocol. So we saw, okay, this is a good strategy that has been backed up by a lot of certainly evidence-based data. And in fact, this fast-track recovery is not just one thing. It's a multiple strategies that combine together. Because, first of all, less invasive surgery, done laparoscopically, trying to improve pain control by using epidurals as well as multimodal analgesic approach, intraoperatively optimized fluid using a goal-directed approach, early nasogastric tube removal, early feeding, and early mobilization. So as you can see here, it takes teamwork to try to get this sort of protocol implemented in your patient populations. So the first group of patients that we implemented this on was on patient undergoing colorectal surgery. And this was essentially the protocol that we modified it and used it at our institution, preoperatively certainly identify those patient population and educate them about the program. Patient's expectation is the key, because if the patient expects that he or she is going to lie in bed for a few days, he or she will lie in bed for a few days. So you have to educate them that you are expected to get out of bed the day after surgery. Carbohydrate drink. We are all familiar with nail by mouth for over 8 hours. You drink nothing from midnight, and it doesn't matter what time of the surgery is, especially if it's in the morning, you don't drink anything since midnight. What we did was we implemented a carbohydrate drink about 2 hours before surgery. And in fact, the patient loved it. And in fact, some of them even asked, "Are you sure that I can drink? I'm not going to have my surgery canceled?" So we actually gave them Gatorade 2 hours before surgery. And in fact, just using that strategy reduces the incidence of hypovolemia, especially when they come initially for induction. Again, we don't routinely bowel prep every patient, only selectively. Intraoperatively, especially in the open colectomy, we routinely put in a thoracic epidural, implement goal-directed fluid therapy in the intraoperative period, because we want to know where the patient is as far as fluid responsiveness. Just like Dr. Marik talked about earlier, we need to know where the patient's fluid status is. And then just like any other good practices, antibiotics administration, thromboprophylaxis. Now, post-operatively, again, we remove the NG2 at the end of surgery, early feeding, early mobilization. As soon as the patient is ready to drink, we gave them the drink, and then we started feeding them, get them out of bed, optimize both fluid as well as analgesic regimen. And with that, we were able to quite significantly reduce. So this was a strategy that we started off. So initially, we collected some baseline data, implemented the training period for about 3 months, and then implemented the protocol So this was the standard of care before the implementation of protocol, and this is after 6 months after implementation of protocol. And you can see the length of stay was significantly reduced, even laparoscopic. As you would imagine, will be much more difficult to show a difference. We were still able to show a difference in length of stay, reduction in wound infection as well as UTI, but we do need to use a little bit higher incidence of phenylephrine U because of the epidural, which wasn't the standard of care in the baseline group. Now, there are many monitors that are on the market that one could consider using for goal-directed therapy. And in our hospital, we use a number of different ones. And the next study I'm going to show you is this is a study that we just completed, essentially comparing NICOM device, which is totally non-invasive, versus a soft tube Doppler, which has, as I showed you earlier, most of the evidence on goal-directed therapy has been done with a soft tube Doppler. So this is the classic blend open analysis comparing both the NICOM versus a soft tube Doppler. As you can see, it's fairly comparable. Most of them is within this 2 standard deviation away. And interestingly, when you compare NICOM with a soft tube Doppler, there are about twice as many data points that were missing in the esophageal Doppler. And I'm sure that those of you who are in the operating room, you sort of use a device and you give a fluid challenge, and sometimes when the surgeons start the electrical cautery, your esophageal Doppler screen that basically is a snowstorm. You can't get a number. And when we compare with NICOM, there were essentially about twice as many times during the bolus of fluid that we were not able to get a data with esophageal Doppler compared to NICOM. So again, this is sort of practical perspective. It is worthwhile knowing that more reliability in terms of data acquisition. Now, I show this really not to suggest that one monitor is better than the other, but just really to show that the length of stay, as we had previously shown that the goal-directed therapy with esophageal Doppler was able to reduce the length of stay, we were again able to show that there was really no difference in terms of length of stay with NICOM. And interesting, if anything, in those patients had an earlier return of bowel sound in the NICOM group compared to the esophageal Doppler group. But again, this is not the primary analysis, and therefore I would not certainly concentrate on these slight differences. So in summary, I think hypovolemia is common, but potentially avoidable. Something that we really need to be focused on in the perioperative period as well as in the critically ill patients. Goal-directed therapy resuscitation, again, improve patient outcome, and again, in those meta-analysis show that not only it reduces mortality, but also reduces complications. Now, I think this is where the future is going to be. I think there's going to be much more of a protocolized care because, again, many studies have shown that using this strategy of enhanced recovery after surgery can, in fact, improve patient outcome, reducing complications, and therefore achieve an earlier discharge for patients. And in the study that I just showed you, NICOM device and the esophageal Doppler performed similarly well in the goal-directed therapy protocol. Most important thing is that now we really need to individualize therapy because every patient may be different. Their fluid status are different when they come to us. Their response may be different. And therefore, in order really to know about where the patients are, it's important to have appropriate monitoring. Thank you very much for your attention. And I have the pleasure to introduce our next speaker, Dr. Paul Heerdt from New York. Paul is going to talk more specifically on the NICOM device, and Paul has a lot of experience. He's probably one of the earliest adopter of the NICOM device, and I'm looking forward to getting some experience from him. Thanks. Let's see here.
I'll start out with a In the context of Dr. Marik's comment about how 50% of the population are non-responders, I will freely admit that my name is Paul and I am not a fluid responder. I have a little subtitle here, which is basically we're going to talk about perioperative application for total hemodynamic optimization, but largely a question of where we've been and I think perhaps where we're going with this. Just as a disclosure, I have gotten some research monies from Cheetah Medical. I'm not talking about any of those data, and our other research is supported by foundation industry and the NIH. I want to start out with an idea of theory of practice. For the last 25 years, I've been involved in looking at a variety of flow technologies, both from the experimental side in the laboratory and clinical application. And in general, I've found, as probably many of you have, that while these devices tend to work in theory, in practice they are often quite limited. So when I got involved in looking at this technology, it was with this jaded perspective that in general things don't work particularly well. And let me talk to you a little bit about the environment that I commonly work in now and give you a patient scenario of a 79-year-old man with this severe progressive dysphagia who prevents for a repair of a large hiatal hernia. On exam, he's hypertensive, he's got high cholesterol, he's got coronary disease with a stent in place, he's had an MI in the past with a reduced ejection fraction. He's got an echo that shows he's got, quote, significant diastolic dysfunction in keeping in line with his long-term hypertension. He's had a long weight loss, he'd actually been on TPN, he's got low albumin, and he's got a CT scan that shows he's got stomach and bowel up in his chest. You see this man, he's thin, he's ill-appearing, he's orthopnic, he's a little tachycardic, he's hypertensive, and he's coming to the operating room to have a repair. So let's just keep this scenario in mind as we go forward. Now, what do we have to work with for monitoring this man? As you all know and we've heard here, we've got our variety of non-invasive devices and lab data and standard monitoring and our clinical judgment based on them, or what we call minimally or moderately invasive of arterial catheterization, central venous catheterization, central venous oxygenation, and then our invasive monitor, of which is largely gone into the past, so we will put that as gone, or one of my favorite, what happens next. But what happens here largely is that we have to keep in mind that although we're seeing the pulmonary artery catheter pass largely, flow management with it still remains the clinical standard to which many new devices are compared. So if we look often, as the previous speakers have described, we have a variety of new things that we can look at here, both non-invasive and moderately invasive. And transesophageal Doppler, as Dr. Gann mentioned, has actually been the basis for a lot of the common reports on perioperative goal-directed therapy. This is a meta-analysis that was done not too long ago that, in keeping with what TJ mentioned, really shows that esophageal Doppler has some real benefits in shortening length of stay. The problem that I have in our population largely is how do we apply this in patients in whom the device can't be used, those, for example, having major esophageal surgery, or on into the PACU or the ICU for postoperative monitoring. Now, as we've seen already a little bit how the device works, there's the electrodes that are placed. Each electrode has two sensors in it, an inner and outer sensor, and a current is applied from the outer sensors, and these are, which I'll talk a little bit about, is very cleverly done. There's actually two sets of measurements, one from each side of the body. It applies a current. Now, we've talked a bit about this phase relationship. I'm not a very smart guy, and I have kind of a hard time visualizing how this works, so I'm going to put up something here that's probably technically not correct, but it provides me a little bit of a visual gestalt of how the device actually generates a signal. We've got then on each of these sensors, there's an inner set of electrodes, and the outer electrodes provide the current, shown with a known frequency in red, and the inner ones sense this current. So the signal actually comes with what they described as the phase delay here. And if conceptually we say that the inner current, shown in yellow, initially they all line up on each other, but as the heart fills, there's a shift in the phase of how the sensed signal relates to the injected signal shown in red. And eventually, we call this a phase shift. And it is then the maximal rate of this phase shift that is multiplied by the time over which ejection occurs and by the ever-present constant that allows for the calculation of stroke volume. Now, as I mentioned, we've pushed this. I have a hard time believing a lot of these things, so before I ever used it in a patient, I used it on myself, my wife, my kids, the dog, my nieces and nephews, and a whole range of laboratory animals. And one of the animal studies that we first did actually involved a study we were doing in dogs that had nothing to do with a NICOM. As part of the thing that goes on in my laboratory is we do a lot of subcontract work where we describe cardiovascular side effects of novel molecules. And in doing so, we use a lot of open chest and other instrumentation. We also do a surgical preparation in this, and once I got initial box, which if you haven't seen it is a simple little light device, it measures non-invasive blood pressure, it gives you an EKG trace, and as a side effect, it also gives you the flow. We started using it in some of these drug development protocols simply as a intraoperative monitoring device. And this is an example shown from a 9.1 male beagle, gave a beautiful trace, a cardiac output of 1.1 liters a minute, a non-invasive blood pressure. We let it run in the background, and as I mentioned, these are open chest preparations with a flow probe on the aorta, which has been our laboratory standard for years. And finally, when I got around to actually looking at some of the data that we acquired in the background with the NICOM, the aortic flow probe is at a 5-second average. The NICOM comes out at a 30-second sample. It looked like this. And I kind of went, this is a little interesting. There may be something here. Eventually, we went on and we looked at a variety of these where we were giving these incremental dosing of these drugs and looking at side effects. This would be heart rate with the derived from the aortic flow shown in black, the NICOM shown in red, and then this is the change in stroke volume that occurred with incremental larger doses of these study compounds. And they actually seem to line up quite well. So eventually we went back and we compiled all these data from a variety of these drug development studies. And this is a paper that we published just this last year, which described the use as a non-invasive alternative to open chest monitoring in these drug development protocols. And it found that it was actually quite precise and it was quite accurate, and we could track changes in blood flow that we traditionally had used with open chest instrumentation. Now, to my surprise, this actually generated a lot of interest. One, it showed a real precision of the device in an invasive model comparison, but it's also generated a lot of interest in the industry and in the animal use side, and I've gotten a lot of emails about this, because what we do now is we do these studies, we don't open the chest, we recover these animals, and we actually give them away. And so it's been an interesting progression of how we do our practice. But, okay, so I've kind of convinced myself that maybe it works in a laboratory setting, but what about in the clinical environment where we all work? And I'd like to progress on in using these things postoperatively. And the truth is that when you're talking about electrodes stuck in the chest, people move. And they wiggle and they squirm and the stuff falls off and you go to check your data and it's gone. So one of the first things I did with this was I actually put it on myself, knowing that at night I wiggle and I squirm. I put the electrodes on, I hit the button, and I went to sleep. And here's what I find. Well, it was kind of interesting. I woke up the next morning thinking there would be gaps in the data, and there weren't, and there's this nice cardiac index. But I saw this area here where my cardiac index was less than 1.5, and my first response is, well, obviously this device doesn't work. Well, I look back in the literature, and there's this paper published in 1967 that was actually looking at cardiovascular responses during sleep, and they found in non-REM sleep, and they put PA catheters and arterial catheters into patients, and found that in non-REM sleep, indeed, there's a profound cardiovascular depression that occurs. And I got to thinking, well, maybe it isn't wrong. I like to drink red wine once in a while, and I was delighted when I saw this paper a couple years ago showing that not 1 but 2 drinks of red wine actually raises your cardiac output and maybe is good for you. Now, I also know that if I drink much red wine, I wake up at night, my heart's pounding, probably from the tyramine absorption, and I don't know if that happens to any of you. But in the sake of science, I thought, okay, and I drank a bottle of red wine, and I put the electrodes on, and I hit the button, and I went to sleep. And here's what I found that was distinctly different. And in the nature of full disclosure, after the red wine, I felt awful, and after this one, I felt great. But sure enough, consistent with what had been published, my baseline cardiac output was substantially higher. And here's this period of time when the cardiac output went way up. And when I tracked it through, exactly what I would find is there's a point where I wake up and my heart's pounding, and the black shows stroke volume, and there was an initial rise in cardiac index that occurred that was entirely stroke volume mediated, and the secondary rise was entirely related to my heart rate. Okay. Well, I know that the leads aren't going to fall off at night and that red wine gives me a hangover, but in the perioperative environment which we work, how practical is this? How really practical is this? And I get to thinking about our patients, many of whom I take care of, that have major intrathoracic non-cardiac surgery, let's say an esophageal cancer patient that's going to have an esophagectomy. And if we take the description of how the leads are placed, And we say, well, actually, the patient may have a subclavian line. They're going to get an incision in their abdomen and their chest and in the neck, and they're going to have a chest tube on one side and a chest tube on the other. They're going to have bandages put over all these things, and a lot of the patients have an AICD pacer, and then they're going to go to the unit and they're going to have leads put all over them. How practical is it with this array of electrodes? Okay, well, maybe the device seems to work, but I don't know how in this perioperative environment it's really going to behave for us. So after approval of the local IRB, my wife, and recruiting a subject who's my son and saying he would be anonymous, we put him down and we put the leads on. He's actually sitting over here today, but we put the leads on in a variety of different arrays, and we looked at what happened. At close, spread out, on the back, spread out, and then flipping them over. And some interesting things came out. First, I don't know if you can see it, but in this array in the back, it's reading that his cardiac output is 4.8 and an enviably low heart rate of 52. We flipped him over, the lead's in the exact same place, but now he's gone from prone to supine, and the cardiac output is 5.5. And my first response is, aha, there's something having to do with the position here that the signal doesn't work and the device doesn't work anymore. Of course, then I found this paper showing that turning healthy patients prone produces a clinically significant cardiac output. So what we did is we detected the change that had been described previously simply by turning them over. All right, the leads aren't going to fall off, or red wine gives me a heading over, and lead placement is adaptable. Does it really have a potential place in our practice? And this is where really the money of all this is. So let's go back to our old man who has a big diaphragmatic hernia and bowel and stomach up in his chest. This guy's coming to the operating room, and to make things even a little bit more interesting, said he's too sick for a laparotomy, so let's do this with a 3-hour laparoscopy. It's little incisions it's got to be better for, and I'm sure many of you have come across this. Now, to be honest, if I need to have a procedure done, and it can be done in a minimally invasive way, and I'm convinced that the outcome is going to be just as good as open, you and me and everybody else is going to opt for a minimally invasive procedure. And as we've seen minimally invasive things come and become expanded, this is a quote from one of the older cardiac surgeons we work with, and during the context of when there was a move towards doing minimally invasive cardiac surgery, he told me once that he thought it was great marketing because patients don't give up about what they look like on the inside. And subsequently, we've had some other quotes that have gone on to this that remember that minimally invasive can be maximally destructive. That little holes on the outside doesn't mean that everything is okay on the inside. And some of our ongoing surgical experiences confirm this. Now, if we think about laparoscopy in particular, it's been known for a long time that even though we tell patients, well, it's just a laparoscopy, you'll be fine, it's actually not a benign intervention. This was published in 1993, a study that couldn't be done, I don't think, pleasantly, in which they took ASA Category 1 patients and they put invasive monitors in them, and they looked at hemodynamic responses to filling the abdomen with gas, creating this pneumoperitoneum. And they found that peritoneal insufflation increased mean arterial pressure, but actually decreased cardiac index over what had occurred simply by the induction of anesthesia. And they then concluded that the combined effect of anesthesia, putting a patient in the head-up position, and insufflation of the abdomen produced a 50% decrease in cardiac index in healthy patients. Well, most of our patients aren't particularly healthy, and they may be elderly. This is a study that then was done using transesophageal echo more recently in 2006. They used echo in 15 patients having laparoscopic aortic surgery. But they found that with pneumoperitoneum, there was an increase again of mean arterial pressure, an increase in LV systolic wall stress that was pronounced, or an increase in afterload, a decrease in ejection fraction, decrease in stroke volume. They found filling patterns consistent with diastolic dysfunction, and they found a greater respiratory variation in right ventricular stroke volume. So there was a rather profound acute hemodynamic challenge that was induced simply by the laparoscopy. Now, this isn't necessarily just, as I mentioned, many of our patients are elderly, but there are a lot of data now, and we're moving these procedures on to using them in children as well. And this is a study that was more recently published looking at the effect of pneumoperitoneum in neonatal versus adolescent pigs. And what they found that at prolonged 180 minutes, and we will not uncommonly see laparoscopies for some of our procedures that are approaching this duration, but they found that it induces hypotension and cardiac depression in neonatal animals, but not the adolescents. And it suggested that in the clinical environment that the neonates that are subjected to this be monitored for an extended period of time because of this potential physiologic disturbance. Now, in our population, as I mentioned again, we do a lot of non-cardiac thoracic procedure. We do a lot of esophageal procedures. And when you pressurize the abdomen, but then you open the diaphragm, gas goes somewhere. You open the diaphragm, it goes up into the mediastinum. It may go into the pleural spaces. You can get a pneumomediastinum and a pneumothorax, and this is something that we deal with quite frequently. This is a study that actually looked at the significance of pneumomediastinum after laparoscopic surgery. They looked at 45 patients. They found that about half of them had extra abdominal gas post-operatively on imaging. The large percentage of those, 86%, had a pneumomediastinum and with pneumothorax, and quite a few patients have subcutaneous emphysema. And in many of you done long laparoscopic procedures, you'll commonly see patients with a large subcutaneous emphysema load of carbon dioxide that they have to get rid of. Now, they mentioned that there were no real evident sequelae of this, but the question that I have is what happens intraoperatively? This is a post-operative study. What happens when this gas under pressure is delivered into the chest during the course of a procedure? Well, let's get back to our patient here, the 79-year-old man with bowel and stomach up in his chest who's orthopnic, has had a major weight loss, has had an MI, he's got diastolic dysfunction, he's had a bowel prep, and the man is miserable, and we're going to do this as a minimally invasive procedure. Now, our common goal for years and years has been trying to maintain a mean arterial blood pressure above 60. That's been an intraoperative goal. And this is actually the blood pressure trace in this patient, and this would be a mean arterial pressure of 60. And inconsistent with his hypovolemic state and his long-term hypertension, you can see there's a lot of volatility to his blood pressure. And we can link this up with specific events. Here's induction of anesthesia. Here's the pneumoperitoneum. Here's where pressure was taken out of the abdomen. Here it was pressurized again, and a pneumomediastinum occurred that produced acute hypotension. And during the course of this, he received phenylephrine intermittently, albumin, other fluids. But in the end, his mean arterial pressure, which was our primary monitoring goal, was less than 4%, or less than 60, 4% of the time. Okay, well, we're standing there watching the arterial pressure, giving fluids and pressors to try to do that. Now, what we had done during our early stages of using the Nikon was we had it on, running in the background, really not using it to make therapeutic decisions. So if we look at what happened simultaneously to his cardiac output, well, one, it started low, but one of the things that really becomes prominent is this is the pneumoperitoneum, and entirely consistent with what had been described in the literature using pulmonary artery catheters, for example. His mean arterial pressure went up, and his cardiac output went down, and in fact, his cardiac index went below 1 for a period of time. Yet his blood pressure, which we treat, is fine. And what we eventually found when we look at the data in this man is that although his mean pressure was less than 60 for 4% of the time, 80% of the time during this procedure, his cardiac index was less than 2, and 26% of the time it was less than 1.5. So I suspect that using pressure as our only index of what was going may not have been in the best interest of this patient. Now, like many of you, we're getting off in doing minimally invasive esophagectomy procedures. This has kind of taken off just in the last month or so. In 2012, there are papers that are published about the increasing application. There are multiple different procedures actually that have evolved for doing minimally invasive esophagectomy. And there are these two that were just published actually this month that had been electronically published before. This one that shows that short-term outcomes are comparable to an open esophagectomy. And this one actually is an editorial that says, well, wait a minute, maybe we aren't quite so sure what we're doing. Maybe there are a lot of questions that are involved. But for those of you that aren't necessarily completely associated or familiar with this procedure, essentially all of the procedures involve taking the esophagus out, taking the stomach, which is now here, shaping it into a conduit and pulling it all the way up into the chest to replace the esophagus that's been removed, and doing an anastomosis here either in the chest or up into the neck. There's a single blood vessel left that actually supplies this whole gastric conduit. Now, we do these the traditional open way. You make a big thoracotomy incision in the chest to localize the esophagus. You make a big laparotomy incision to make this gastric conduit, and then you pull it all up together. What's happened now with the minimally invasive procedure, though, is the mobilization of the thoracic esophagus is done with videothoracoscopic approach. So there's lung collapse, VATS thoracoscopy. Then you use a laparoscopic procedure to mobilize the abdomen. And then there's a small incision made, the stomach is pulled up, and there's a gastric conduit that's created. The esophagus is then moved, and the remaining esophagus in our institution, we actually do a neck incision. So the esophagus is removed, the gastric conduit is pulled all the way up, and there's an anastomosis in the neck. And some clinicians actually, at the end of the procedure, will perform a laparoscopy again to inspect internally that all the parts are back where you want them and nothing is kinked, to actually look at the efficacy of the intra-abdominal portion of the procedure. Now, we started using the NICOM a few years ago when we were doing open esophagectomies. Large incision in the chest, open laparotomy for an extended period of time where you're losing 10 or 12 cc's per kilo per hour of fluid, a large volume loss, and the neck anastomosis. And we began to notice that there were a number of different things. And this, for example, is a patient who had a procedure done. It was the standard, what we call a 3-field esophagectomy. They're admitted to the ICU, somewhat hypotensive. Intraoperatively, they had a 400 cc blood loss, 6,100 cc's of LR, some albumin that was given. And part of the management here is, fluids can come back to haunt you in 48 hours, which we always worry about. But the classic thinking in these esophageal anastomoses has been, yes, but if you give a pressor, you're going to kill the anastomosis. So we've always been bouncing around these, and I'm sure many of you have run into the units with the same sort of management controversies. One of the things we began to notice, for example, in this patient is during the latter portions of the intraoperative procedure, when the laparotomy was done and the gastric conduit was being pulled into the neck, the systolic blood pressure tended to drift down as if there was vasodilation or hypovolemia, and using blood pressure and CVP as a guide, the patient continuously got more volume. But when we went back and we looked at the NICOM running in the background, what we're finding here is the cardiac output is rising. So we're looking at a vasodilatory state, and we're giving more and more volume. And then when the patient was actually admitted to the ICU, they had a cardiac index of 4.7 liters per minute. The thought was here, we can't use a pressor to control blood pressure. We have to use volume. Yet I submit to you that maybe when your cardiac index is 4.7, you have a little room to use something that's going to give you a little more vascular tone. Taking these things on into the post-op environment, we began to notice some other things. This, for example, is one of our early open esophagectomy cases. Admission to the ICU here. This is cardiac index. And what we find is over time, they have a large volume loss and the cardiac index falls. In fact, it was quite low. As we got a little bit more sophisticated and we began to feel a little bit more comfortable about using the device to help us guide volume, we began to see that we would intervene sooner, generally gave more volume. And if we look at things like oxygen delivery, this one in red, delivery was low the entire time, whereas this patient here that had an intervention done early, we were able to run the oxygen delivery higher. Well, this is for an open esophagectomy, where we've had a large volume loss and a large ongoing volume loss. What about the minimally invasive procedures, where we're not looking at an open bowel for a long period of time, where we're not losing this kind of volume, and where the insult is transient? For example, if I give a lot of fluid to one of these patients when they're upright with a pneumoperitoneum, what happens when we take the pneumoperitoneum away and we lie them flat, but I gave them a large amount of volume to maintain hemodynamic stability? And it gets even a little bit more complicated here. We're talking about prolonged single-lung ventilation, which is an insult to the lung. We have the head-up position, again, which is causing hemodynamic disturbance along with the pneumoperitoneum. From a respiratory standpoint, we have decreased respiratory compliance. We have a large VQ mismatch. There's always a hypercarbia that occurs because of hypoventilation and the CO2 load that the patient got intraoperatively from the pneumoperitoneum. Then we have the issues related to the gut manipulation and reperfusion that are always worrisome. And at the end, once we've reached an equilibrium, we often do another pneumoperitoneum for another laparoscopy, and we hit them again. And the big question of all this, obviously, is where do we stand for short versus long-term fluid requirement? If we give them a lot intraoperatively to offset this, but then we take away the insult, is this going to come back to haunt us postoperatively? And our big concern at this point relates to lung injury. Well, we've hit the lung once with the single-lung ventilation. We've hit it again with the high ventilatory pressures that it requires for the pneumoperitoneum. And once they settle that, we do another pneumoperitoneum and we hit them again. So we worry about the lung injury. We end up with acid-base balance, both potentially from hypoperfusion and the hypercarbia that we tend to run into. How does this influence with our real push to try to extubate these people early? And in the big picture, what happens to the anastomotic viability? We can do this great procedure, but if the anastomosis falls apart and the patient gets a large leak post-operative, we really failed them. Well, this is a minimally invasive esophageectomy, again, early in our course here, where the management goal is primarily maintaining mean arterial pressure greater than 60. The black is the heart rate, the blue is the cardiac index, and the green is the stroke volume index. And a general idea has been try to keep our cardiac index above 2, and if you look in the literature, there's been approaches to keep stroke volume index above 30. Here's what we see again. Here's the pneumoperitoneum with a sharp drop in the cardiac index and a sharp drop in the stroke volume index. And when we go back later on and we look at this patient, again, this is a minimally invasive esophagectomy. 3% of the time do we have mean arterial pressure less than 60. 40% of the time, though, the cardiac index is less than 2, 7% less than 1.5. And we have a large period of time when the stroke volume index is less than 30. Well, we went back and we looked at a number of patients that we had done where we weren't using the NICOM as a primary therapeutic intervention, and here's what we found. This is a small sample, and this is, again, more phenomenology than pure science at this point. But we find that the time, again, with the mean arterial pressure less than 60 was 4%, yet nearly 50% of the time in all of these patients did we have a cardiac index less than 2, nearly 5% the index was less than 1, and when we would get to the end and we try to decide whether or not to extubate these patients, and we're taking base excess into our consideration here, virtually always the change from baseline has been significant. So we've started to try to approach this a little differently, and instead of just using mean arterial pressure, we're now trying to keep our flow up during the periods of time when we have the pneumoperitoneum and the upright posture. What we're trying to do at this point is make up for most of these patients have had a bowel prep, so we're trying to initially get them back into some range of normal volemia. Whenever possible, we're actually trying to do some heart rate modulation. A lot of these patients are bradycardic or they become bradycardic, and we're trying to keep their heart rate up. We now realize that we may want to do an early transition to dobutamine for low flow states instead of giving volume that we're not going to be able to get back later. And the other thing we're trying to do is maintain our monitoring that we do intraoperatively into the post-op phase as well. And let me give you an example of one of the more recent cases. This is a man, a 73-year-old man who did have coronary artery disease. And here we have his cardiac index of 2, and in this patient you can see intraoperatively we were able to maintain his cardiac index much higher. This was largely done simply by modulating his heart rate. He was heavily beta blocked, had a very slow heart rate, resting heart rate less than 45. And by simply raising his heart rate up into the range of the upper 60s, we're able to get a larger cardiac index. Interesting thing you can also do with these devices is during the course of his procedures, every time we measured his hemoglobin, it was between 10.8 and 11, 11.2. So we picked 11 as a mean value, and we actually calculated an oxygen delivery over this period of time, which we were largely able to keep over the 400 level. Importantly, at the beginning of the portion of this procedure, his base excess was 1, and unlike most of the open procedures, the other ones we'd done where we didn't monitor flow, the base excess now was only 0. We've gone back and looked at 4 of these patients where we were using flow as an endpoint, not just pressure, and we find that about the same amount of time as the mean pressure less than 60, but only about 5% of the time do we have the cardiac index less than 2. And interestingly enough, we're looking at the end, when we're trying to decide whether or not to extubate these patients, we're not looking at such a large base deficit. So last thing in this idea of total perioperative or hemodynamic applications, what else can we do with this? Well, we use it quite frequently for simple pre-induction interventions. This, for example, our traces. This is cardiac index, heart rate here in blue, and the stroke volume in red. Of a patient who is an end-stage renal failure, had dialysis prior to coming to the operating room, long-standing hypertension, echo shows really severe diastolic dysfunction. I'm not sure I want to dump a lot of volume quickly into a patient with that severe diastolic dysfunction. So prior to induction of anesthesia, he has a passive leg raise. He has a pretty prominent response in his passive leg raise. We know he's going to be fluid responsive. So as part of his induction, he receives fluid, he receives more fluid, he receives albumin. But what we did here was a simple passive leg raise to determine whether or not this man with this diastolic dysfunction was still fluid responsive. What about non-invasive monitoring in children? This is my nephew, by the way. And as a transfusion guide, one of the people I work with these days does a lot of major craniofacial procedures in children where they have a substantial blood loss, and they set a trigger for their hemoglobin. Once the hemoglobin falls below that trigger, they transfuse the kid. But at the same time, you're seeing a lot of these children have marked capacity to adapt to the stress of being anemic. And they will push their heart rates and their cardiac outputs up very high. So one of the thoughts is using oxygen delivery. Yes, the hemoglobin is low, but if they've compensated from a cardiac standpoint and maintain their oxygen delivery, do they need to be transfused? Another thing that we've started to do is this idea of preoperative evaluation, which is the device is now made with oximetry. You can take it, you can walk with the patient with the oximeter on, you can put the blood pressure cuff, you can actually walk them up and down stairs, which we've been doing. And this, for example, is a lady with obstructive disease and a decreased diffusing capacity preoperatively, starts with an oxygen saturation of 97%. She walks up 2 flights of stairs, says she can't go any further, and her oxygen saturation falls to about 92. We look what happens simultaneously to her cardiac index, it rises, and if we integrate the hemoglobin, the saturation, and the flow together, we come up with an oxygen delivery. Now we have a 68-year-old male who also gets winded at 2 flights, starts with an even lower oxygen saturation, falls to 92, but in this patient he raises his cardiac output much more substantially, and he actually raises his oxygen delivery higher. And what we're wondering now is, does this reserve, not from a pulmonary standpoint, but from a cardiac standpoint, have some predictive value as to how well these people will do perioperatively? And even more so, if we're worried about how much lung to take out, and we say that the patient can't tolerate a lobectomy, does this help decide whether or not they should have a lobectomy versus something like a segmentectomy? This is another one that I wanted to put in here. This is a 77-year-old man with an ischemic myopathy and ejection fraction that's low. He's got atrial biventricular pacing at 60. Black is his heart rate. As you can see, it's a straight line. Here's his stroke volume, which is there. This is his cardiac output, not index at this point. The red actually represents a simultaneous continuous cardiac output PA catheter. What is of interest here is this is actually doing a HeartMate 2 continuous continuous flow LVAD. The red shown here is the monitor, is his arterial pressure with a pulse pressure 4 millimeters of mercury. This is the oximeter, which there's no pulsatility on, but again, since the right ventricle is normal and pumping away. And what the black dots here actually reflect are the flow from the LVAD. So it surprised me, 1, that we get a signal that works, and 2, that the device is providing flow, which is actually quite close to what we measure with the PA catheter and off the LVAD itself. And finally, there's this one that I wanted to show you. Now, a cardiac output of 21 liters a minute, okay, in a trained athlete, maybe that makes sense. But at a heart rate of 46 and a stroke volume of 461 milliliters, something's just not right here. Well, actually, this is a 318-kilogram horse. Now, Cornell University has a large equine facility at their veterinary school, which is a phenomenal place. I have been up there recently to do these studies. And I don't know if many of you know this, but they do a lot of racehorse work. And a lot of these animals, their resting heart rate is around 30. And they will anesthetize them. They will put them in a supine position with their legs up. The big worry in these expensive racehorses is a myopathy. They're on their back, which is not a natural position. Their flows, their blood pressures are low, and they worry about perfusion of the legs. And if you get a myopathy in a very expensive racehorse and they can't run, you're screwed. So they commonly use dobutamine as a background, and they run dobutamine to maintain the blood pressure in these animals without any idea of what it's actually doing to flow, because they have data to indicate that probably not the incidence, but the severity of the myopathy is much less. And it was in this context that we used the device. Now, I had no idea. In fact, I was a little surprised we were able to generate such a signal. But if you look at it, it's pretty interesting that the reported cardiac index for anesthetized horses receiving dobutamine is in the literature between the mid-50s and the mid-70s. If we take this 21,200 mils per minute divided by 318 kilograms, it's 66 milliliters per minute per kilogram, right in the predicted range that's been measured by a variety of others. And I was quite surprised by this, but it was very intriguing to see. So anyway, in summary, what do we have? Well, this device is easy to apply, and it's certainly adaptable to clinical conditions. The impact of the NICOM on the perioperative outcome remains to be determined, although I think work that, like Dr. Gann is doing, is beginning to show that it does have adaptability to goal-directed algorithms and may actually prove particularly useful in those scenarios. Now, with our increase of understanding of the methodology and the expanded clinical and experimental applications, standing people on their head and being able to integrate this information with a variety of other physiologic variables, I think is incredibly profound. And the fact that you just put the electrodes on the chest, it's easy to do. it is I'm finding that the signal is remarkably powerful, and I really think we've only kind of scratched the surface of what the potential applications of this are. And with that, I'll stop. Thank you all very much.